Warm greetings to everyone. Today we will be discussing the topic periodontal pocket with your presenter Dr. Radhika, Associate Professor from the Department of Periodontics from Chettinad Dental College and Research Institute. Periodontal pocket is defined as a pathologically deepened gingival sulcus. Deepening of gingival sulcus may occur by coronal movement of gingival margin or apical displacement of gingival attachment or combination of above. Pocket is further divided into gingival pocket or periodontal pocket. Gingival pocket is formed by gingival enlargement without destruction of underlying periodontal tissues. The sulcus is deepened because of increase in bulk of gingiva, whereas periodontal pocket produces destruction of supporting periodontal tissues, thereby leading to loosening and exfoliation of the teeth. Periodontal pocket is further subdivided into suprabony and infrabony pocket. Suprabony pocket is also known as supracrestal or supraalveolar pocket, in which the bottom of the pocket is coronal to the underlying alveolar bone, whereas infrabony pocket is also known as intraalveolar or subcrestal pocket, in which the bottom of the pocket is apical to the crest of alveolar bone. Pocket is further divided into simple pocket, which involves one surface, compound pocket, which involves more than one surface, complex or spiral pocket, which originates on one tooth surface and twisting around the tooth to involve one or more additional surface. Pathogenesis of pocket formation. Presence of bacterial plaque on the tooth surface causes inflammation of the marginal gingiva. The gingival sulcus deepens due to edematous enlargement of gingiva, which causes gingival pocket. The anaerobic organisms tend to colonize the subgingival plaque. A large number of PMNs, nucleides, and macrophages migrate to the gingiva tissue in response to bacterial challenge. The two mechanisms of collagen loss are lysosomal enzymes and the activity of fibroblast phagocytose. When the collagen fibers apical to the junctional epithelium get destroyed, the epithelial cells proliferate along the root surface in an apical direction until they become contact with healthy collagen fiber. At the same time, the coronal portion of junctional epithelium gets detached from tooth surface. The PMNS cells migrate towards the coronal portion of junctional epithelium. When volume of PMN leukocytes at the coronal portion of junctional epithelium exceeds 60%, the epithelial cells separate from the tooth surface. Thus, the pocket forms. Plaque removal is difficult or impossible from deep pocket, favoring growth of pathogenic organisms in the protected environment. Further attachment loss and horizontal bone loss is observed. If trauma from occlusion presents, then vertical bone loss also can occur. The various clinical features of periodontal pocket: bluish-red discoloration of gingival wall of pocket, flaccidity, a smooth shiny surface, pitting on pressure, gingival wall may be pink or firm, bleeding on probing, probing is generally painful, and pus may present. Bluish-red discoloration of gingival wall of pocket occurs due to circulatory stagnation. Flaccidity occurs due to atrophy of epithelium and edema. Pitting on pressure occurs due to edema and degeneration. Gingival wall may be pink or firm when fibrotic changes predominance over exudation and degeneration. Bleeding on probing presents due to increased vascularity, thinning and degeneration of epithelium, the proximity of engorged vessels to the inner surface. Probing is generally painful due to ulceration of inner aspect of the pocket wall. Pus may present due to suppurative inflammation. The other clinical features are thickened marginal gingiva, loss of stippling, tooth mobility and diastema formation. Histopathology. Soft tissue wall or lateral wall shows changes in the epithelium as well as the connective tissue. The epithelium shows both proliferative changes as well as the degenerative changes. Epithelial cells proliferate into underlying connective tissues forming deep retipex. Micro-ulceration develops on the soft tissue wall. Pocket epithelium is infiltrated by PMNS and edematous fluid from inflamed connective tissue. Bacterial invasion in intercellular space of epithelium. In connective tissue, it shows edematous, densely inflated with plasma cells, high vascularity, blood vessels dilated and engorged, area of necrosis and degenerations are observed, suppression is commonly seen. Scanning electron microscopic examination of lateral wall shows area of relative quiescence, area of bacterial accumulation, area of emergence of leukocytes, area of leukocyte-bacterial interaction, area of intense epithelial desquamation, area of ulceration and area of hemorrhage. Periodontal pocket is known as a healing lesion. Periodontal pockets are inflammatory lesions and constantly undergoing repair. Complete healing does not occur because of persistence of bacterial attacks, which continue to stimulate an inflammatory response, causing regeneration of new tissues. Edematous pocket wall occurs when the inflammatory component predominates the lateral wall, appears soft, edematous, friable with smooth shiny surface and bluish red discoloration. Whereas fibrotic pocket wall occurs when the reparative changes predominate, the gingiva appears fibrotic and pink. In some cases, outer surface of soft tissue wall is fibrotic while inner surface of soft tissue wall is inflamed and ulcerated. Contents of pocket predominant by microorganisms, bacterial products, GCF, remnants of food, salivary mucins, desquamated epithelial cells, and leukocytes. Purulent exudates may be seen. Deep pocket may have little or no pus, and shallow pockets may have extensive pus formation, so pus is not an indication of depth of the pocket. Root surface wall of the pocket. The root surface forms the medial wall of pocket. The root surface that gets exposed to the oral environment as a result of periodontal attachment loss undergoes following changes such as structural, chemical, and cytotoxic changes. Under structural changes, exposure of the cementum to the oral environment causes mineral present in the saliva tend to get deposited on the cementum surface. So, area of hypermineralization occurs. Root surface is exposed to oral fluid and bacterial plaque. Proteolysis of embedded remnants of Sharpie fibers. Area of demineralization occurs. Root caries may occur, soft and leathery on probing. Patient feels severe sensitivity. Pulse exposure may occur in severe forms. Under chemical changes, the cementum exposed to saliva may absorb calcium, phosphorus, magnesium, and fluoride. Increased mineral content of the root surface alters the chemical composition of cementum, making it resistant to dental caries. Under cytotoxic changes, histologic studies of predominantly involved cementum have shown the presence of bacteria in cementum or endodontins in the cementum. The 5 zones can be seen at the bottom of the pocket shows calculus, unattached plaque, junctional epithelium, partially lysed connective tissue fibers, and finally the intact connective tissue fiber. Diagnosis of pocket, careful exploration with the periodontal probe and radiographs. The drawbacks of radiographs shows it indicates area of bone loss where pocket may be suspected. They do not show pocket presence or depth. Radiographs show no difference before or after pocket elimination unless bone has been modified. Gutta-percha points or calibrated silver points can be used with radiographs to assist in determining the level of attachment of periodontal pocket. Pocket probing. Two different pocket depths. One is biological or histological depth, which is the distance between gingival margin to the base of the pocket, whereas the clinical probing depth, which is the distance from the probe penetrates into the pocket. Pocket depth is the distance between the base of the pocket to the gingival margin, whereas clinical attachment loss is the distance from the base of the pocket to the fixed reference point such as clinical cemento-enamel junction. Probing techniques. 6 surface measure in periodontal probing, which includes facial, distrofacial, mesiofacial, mesiolingual, lingual, and distrolingual. The probe should be inserted parallel to the vertical axis of the tooth and walk circumferentially around each tooth to detect the area of deepest penetration. To detect internal crater, probe should be placed obliquely from both facial and lingual surface so as to explore the deepest point of pocket located beneath the contact point. In the multi-rooted teeth, the possibility of first-section involvement should be carefully explored with the specifically designed probes such as Neighbor's probe. Bleeding on probing. If gingiva is inflamed and the pocket epithelium is atrophic or ulcerated, to test for bleeding after probing, the probe is carefully introduced to the bottom of the pocket and gently moved laterally along the pocket wall. Bleeding may occur immediately after the removal of the probe or may be delayed a few seconds. Depending on the severity of inflammation, bleeding can vary from a tenuous red line along the gingival surface to profuse bleeding. Probing around the implants. Periimplantitis can occur, create pocket around the implant. The plastic probe should be used instead of usual steel probe used for the natural dentition to prevent the scratching of implant surface. To conclude, periodontal disease may increase the risk of many systemic diseases. So periodontal pocket are sign of periodontal disease and their depth is a key indicator of the severity of the condition. Early diagnosis and treatment are essential to prevent further damage and tooth loss. Treatment options include scaling and root cleaning, adjuncting antibiotics, and some cases surgical procedures. Prevention through regular dental care and good oral hygiene is crucial. Thank you for listening.